So the floor goes up 45 degrees.
We'll keep
It's
it 18,
vulnerable.
18 minutes. Huh?
Pardon?
18 minutes.
18 minutes, yeah. Is that, you can, no timers, but let me know. So the floor is the most vulnerable because it goes up at 45 degrees, and so is the medial wall, it's paper thin. We are going to talk about the floor in this lecture. Approaches, the goal is to have exposure and cosmesis. Floor is by conjunctival, subciliary, mid-tarsal, infraorbital rim and endoscopic assisted approach. Conjunctival popular approach nowadays, it was described by Tessier. You can do it with or without canthotomy, pre and post septal approaches. So this is a typical subconjunctival approach. You need to do a force duction test, and then you give the incision posterior to the tarsal plate. Retrieve the fat and the muscle entrap and close it. The subciliary approach is a popular approach also. Generally, if you give it in the crease, there is no scar, and there can be a temporary ectropion which you can avoid in almost all cases. But the problem is the medial exposure is less. The subciliary approach, everybody should know, there are three options how to give it. The converse option, that is the stepped incision, option number 3. Option number 3 is the best, where you give skin incision for 4 to 5 millimeters, then you enter the muscle. The idea is to not damage the pretarsal fibers of the orbicularis oculi. That can cause ectropion. If you follow this, you will almost never have an ectropion. So just a skin flap for 4-5 millimeters, then enter the muscle, then go down to the bone. So this is a typical subciliary incision. First crease, the second crease will be the mid-tarsal, and the infraorbital is the third crease. There is no single incision which is the best. You should master all, and then depending on the clinical situation, use. Most of the times you will be preferring a subconjunctival or a subciliary approach, but even a mid-tarsal approach, if there is a good crease, is a decent approach. Infraorbital, most of the times the crease is lost over here in the midline. So if you are going infraorbital, the patient should have a good crease, and don't give like a U. Always stick to the crease. Don't create a crease. Okay. And like in the northeastern population, infraorbital is a no-no, because there are no creases. So you have to customize your surgery according to the situation. So it's a stepped incision, and then so you have skin only, then you enter the muscle, then the bone, then suture the periosteum. Don't suture anything else straight away, suture the skin. And as I said, don't create a crease. So this is an example of a white-eyed blowout fracture repaired with a transconjunctival incision. This is a late fracture of orbital blowout fracture with a subciliary approach using an iliac bone crest. So you need to be versatile. You can't be dogmatic in any parts of surgery. So this is a video demonstration. Now you can see it's a very bad fracture, Leaford 1 with a zygoma. There is no infraorbital rim. It has almost come out laterally. Now here we have decided to repair the entire zygomatic complex and the orbital floor and the rim via the transconjunctival approach. Here we have to give a canthotomy. So you can use either a cold steel blade or Colorado needle or radio frequency, depending on where you are practicing. Give an incision. This retractor is important. It is known as a DeMar retractor. All soft tissue surgeries are basically traction and counter traction. Whether you are operating in the neck, you are on the nose, or you are in the eye. It's traction, counter traction. Okay? Some people start with the canthotomy. I try to do the canthotomy later. Here you need to go straight to the bone. Okay, this attaches to the bone, so you must go straight to the bone. Once you have, then the entire thing opens up. Then you can take a flap, suture it. Either you can use a corneal shield, or in this case I'm using a cotton.
Ask for malleable retractors.
Now again, you now will change from a Demar retractor to a cat's paw retractor, and I will be then now taking a malleable retractor my side for traction and counter traction. All this surgery is done with magnification and illumination. So now in this case the orbital floor is almost really gone down, almost like a centimeter. What is your landmark? Your landmark is a thin periosteum that is known as arcus marginalis. The video is 18 minutes, which shows fixation also. So this is the arcus marginalis. Now your incision is actually on the rim, never in the floor of the orbit.
Okay. Now that is the part. Nice section. Floor is totally transformed.
Right? And then you do a subperiosteal. That is most important. The subperiosteal dissection. I have trainees who are always scared about orbital floor exploration. It is very straightforward. If you are subperiosteal, nothing goes wrong. And you should always be subperiosteal. There is no business to go supraperiosteal. Now we are fixing the fracture, passing wires for the reduction, and then fixing plates.
Okay. Pause.
So the zygomatic complex, single incision for most situations you can, get away. I'm lifting the zygomatic complex. So once you have fixed what you have to fix, then you have to take periosteum stitches. Periosteum is a very thin periosteum. You have to identify and take sutures with 5/0 vicryl. That secures a layer before your, after your implant.
I don't know if it can be identified on the iPhone.
It's a very, very thin periosteum, if you can see. Now here the most important part is, this is where your canthal tendon is detached. You have to secure it high up in the orbit where you have cut it. So that is the most important thing. Reattachment of your canthal tendon. Yeah. I'm going to go ahead with the video. Please make it.
To add a point that in every case we do orbital trauma, we don't have to do a lateral catheter, right? So if you do a lateral periosteal dissection very well, you can avoid lateral catheter. When I'm only fixing a absent, right? Only that time I'm doing a lateral catheter. So it will come with experience.
Yeah.
Right?
So the case we will be discussing, Siddhartha,
right.
in our this thing.
Second thing is, Or we don't need to, sometimes we, in trans calls,
So,
we need to put the periosteal suture. I'll talk
I want them to, yeah, we will be discussing this in our this thing. So this is now the, with the 4O vicryl, I have taken a bite from the canthus where it attaches to the lower eyelid, okay, and then volume. Then I'm going up in the orbit, medially where the residual part, the main part of the canthus is there, and this reattachment is very important.
Okay. Perfect. Incision closure is to get the canthus back.
Once your canthus is secured, don't tighten the stitch. Just leave it long, then start suturing your conjunctiva. Once you almost start from medially, prevent the, getting the canalicularis. From medially you go laterally.
I used to take a
Using this, I am using 6-0 vicryl rapid.
I can take a
Okay. The canthus is not fully tightened. उसपे stitch लेके रख दिया है. Don't tighten it, because if you tighten it, you can't close your conjunctiva.
Rapid. It's not available at all.
Does everybody understand that?
Pre-ordered it and kept it ready in your hospital. If you're doing visiting work especially, take single.
You want to ask Siddharth something? So this is a 6-0 vicryl rapid. You can use running sutures.
We have given a bigger.
So once you are almost there, and then you tighten your 4-0 vicryl, that is your lateral canthotomy.
Okay. You taking 6-0 vicryl rapid suture.
Round 3 minutes. Round
Yeah.
3.
So then, after that, you take your skin sutures. So this is the case where there is late 6 months old trauma. The entire bulbar conjunctiva and
So in this patient,
so transconjunctival cannot be given over here. There was so much scarring that the bulbar conjunctiva and the palpebral conjunctiva had become one unit. I couldn't even pass my Dema retractor. So that's where you have to be versatile. Now here, if you are only a transconjunctival guy, you won't be able to manage this case because of severe scarring. The entire thing has become one unit.
factor
You see?
over here.
So here we gave a subciliary incision. So we are all used to titanium meshes, but this is again a very big blowout, very late. Good old iliac bone crest or cranial bone. This is how you secure it. Okay, you can use a cantilevered plate and then fix it. So for a very late, fractures, a thin 2 mm, 3 mm titanium mesh is insufficient. That time to use a bone graft is very important, or a PSI. So that's where you have to be versatile. You can't say I'm going to do only transconjunctival or I'm going to do only titanium meshes. You have to be versatile. You should be, you should be able to take bone grafts. You should be able to take cranial bone grafts, iliac bone grafts. You should be able to give all your cutaneous incisions well. I know some oculoplastics who are good at transconjunctives, but they won't give subciliaries. And I know maxillofacial surgeons who are good at subciliaries and won't give transconjunctivals. That shouldn't happen. So this is her immediate post-op, and this is her after, I think, 1 month.
पायल कब हुई आपकी surgery?
This is her 3 months. So this will continue to improve over 6 months of time. Okay, so from no movement to this much amount of movement.